Welcome back to the third part of our myocardial infarction series. So far, we have covered coronary anatomy, ECG changes, the evolution of myocardial infarction, symptoms, troponin-based diagnosis, and even the Sgarbossa criteria for detecting MI in left bundle branch block. In this video, we will focus on the management of myocardial infarction, the initial steps like oxygen, aspirin, and nitrates, the key medications including antiplatelets and anticoagulants, and finally the big one, reperfusion therapy, whether by fibrinolytics, PCI, or a CABG. Let's dive in. Initial steps of management include giving oxygen at 2 liters by nasal cannula when the SpO2 is less than 90%. Chest pain is treated with sublingual nitroglycerin, and if the pain is not relieved and the patient is not hypotensive, morphine can be used, usually 2.5 to 5 milligram IV and repeated when needed. Dual antiplatelet therapy is started as soon as possible with aspirin and an ADP receptor inhibitor. Aspirin is given at a dose of 160 to 325 milligram orally and is chewed for faster absorption. And the clopidogrel is used as the ADP receptor inhibitor. This applies for both STEMI and NSTEMI, regardless of whether the patient is undergoing PCI or not. A third antiplatelet agent can be added in patients undergoing PCI, in STEMI, or in high-risk NSTEMI patients undergoing PCI. This refers to the glycoprotein 2B3A inhibitors, such as tirofiban, and can be considered in these situations. Anticoagulation is also part of the initial management. Unfractionated heparin is given in STEMI and NSTEMI and is started as soon as possible and is given during the whole hospital stay or until PCI is performed. Other drugs that should be given in the setting of STEMI and STEMI or unstable angina include beta blockers such as metoprolol, which can reduce the cardiac demand provided that there are no contraindications like hypotension, bradycardia, or asthma. ACE inhibitors, for example captopril, are also recommended and can be switched to ARBs if the patient develops angioedema. And lastly, statins, for example atorvastatin, can be started routinely regardless of the patient's baseline lipid levels. Before we dive into the management algorithms for STEMI and NSTEMI, let's first talk about the key procedures used to restore blood flow to the heart. Understanding these will make the treatment steps much easier to follow. First, PCI, which is percutaneous coronary intervention. This begins with coronary angiography, where a catheter is inserted through the radial, brachial, or femoral artery and is guided up to the blocked coronary artery. Once the obstruction is identified, a balloon is inflated to open the vessel, and a stent can be placed to keep it open and restore blood flow. Next, CABG, or coronary artery bypass grafting. This is an open heart surgical approach. The chest is opened through a midline sternotomy, and the patient is placed on a cardiopulmonary bypass machine. The heart is then stopped using a cardioplegic solution, and then a vessel, usually or could be the internal thoracic artery, radial artery, or saphenous vein, is harvested and grafted onto the coronary artery beyond the area of blockage. And that's how we create a new route for blood to reach the heart muscle. Finally, fibrinolytic therapy. This treatment dissolves the clot by converting plasminogen to plasmin. Common agents include tissue plasminogen activators like alteplase or streptokinase. Fibrinolysis is avoided in patients who are actively bleeding or at high risk of bleeding. Now that we have covered reperfusion strategies, we can move on to the management algorithms for STEMI and NSTEMI. Now, let's move on to the management of STEMI. In patients presenting with STEMI, the preferred treatment is primary PCI, and it should be performed within 120 minutes from first medical contact. When PCI is available, the first step is to perform coronary angiography. This allows us to visualize the coronary arteries and decide whether PCI is suitable based on the patient's anatomy and the location of the blockage. If PCI cannot be performed within 120 minutes, then fibrinolysis should be given. Now, if fibrinolysis fails, meaning the patient still has persistent chest pain or the ST segment remains elevated 60 to 90 minutes after administration, then a rescue PCI should be performed. On the other hand, if fibrinolysis is successful, an elective PCI is recommended within 2 to 24 hours to stabilize the vessel and reduce complications. Guideline recommendations differ slightly. The European Society of Cardiology recommends a 120-minute window for PCI. The American Heart Association recommends a 90-minute target for treatment when a patient presents directly to a PCI capable facility. If the facility does not have PCI and the patient needs to be transferred to another hospital, the goal is to achieve treatment within 120 minutes. CABG, or coronary artery bypass grafting, is considered when the anatomy does not favor PCI, when a large area of myocardium is at risk, or when the patient is presenting with cardiogenic shock. However, if the PCI has already failed, going directly to CABG will not solve the problem quickly enough because the delay from preparing and performing surgery will worsen the ischemia. In the management of NSTEMI, if the case is uncomplicated, angiography should be performed within 24 to 48 hours of presentation. If the coronary anatomy is favorable for PCI, percutaneous coronary intervention (PCI) should be performed. However, if the anatomy is not suitable for PCI, coronary artery bypass grafting or CABG could be considered. In cases where the patient presents with hemodynamic instability, as well as cardiogenic shock, recurrent chest pain, mechanical complications such as acute mitral regurgitation from papillary muscle rupture, also acute heart failure or arrhythmias, immediate angiography is indicated, and if the PCI is suitable, then we go ahead with PCI. If not, then we can consider CABG. It is important to note that fibrinolysis is never done in NSTEMI patients. And that summarizes the management of myocardial infarction, starting with the initial medications and then moving through the pathways for STEMI and NSTEMI, whether that involves PCI, fibrinolysis, or CABG when indicated. I hope this provided a clear overview. Thank you for watching and see you in the next video.